Hello, my name is Dr. Nava Siegelmann Danieli. I'm a medical oncologist, and I'm here to review some updated data on multigene molecular assessment for early breast cancer and their implication for systemic treatment considerations. And these are my disclosures. So we deal with enormous load of breast tumors of over 2 million new cases every year, and over 600 deaths related to the disease. And the majority of new breast cancer patients, especially in Western countries, and we can see that it's very common in the US and Europe and Israel as well. They are in women in their early 60s, so they're postmenopausal. And so we'll just focus on the traditional systemic consideration and then on some of the commercial available multigene assays with Oncotype, MammaPrint, and Prosigna. And we'll just briefly go over the classical breast structure. So we see here on the left the breast, we see the fat tissue, and we see the glands and the ducts going to the nipple. And this is a cut through one of the ducts. And we see the lumen, but actually all the cells in the breast tissue originate in the stem cell, which transfer to the common progenitor, and most of the breast cancers are from the luminal progenitors, and then they will divide into the luminal A, luminal B, HER2-enriched, and most of the basal tumors. And here we just look under the microscope, and you can see in the top normal breast structure with the ducts and the lobules. And on the left bottom, we see the ductal carcinoma in situ, which are like cancer cells growing in a straw, but they don't invade the tissue. And on the right-hand side, we see the invasive breast tumors invading into the fat tissues. And so we're going to continue with this lecture dealing only with early invasive breast tumors. And we have some classical considerations, and the anatomy, the size of the tumor, and the lymph node involvement are very important, and we're not going to abandon them for the new multigene assays. We'll still keep it in mind. And here we see the classical staining. On the left-hand side, we see high-grade tumor with a lot of the cells going through proliferation. Close to it, we see the estrogen receptor, which are stained in the nuclei, and they're both prognostic and predictive. And on the right-hand side, the two slides, we see the HER2. One is for the protein in the membrane, and one is for the fish, assessing the copy number of the HER2 in the nuclei. And we also consider the patient age, their menopausal status, other diseases, comorbidity, and of course, their personal preferences. And so we can do more extensive work to assess the tumor type of the breast cancer using unsupervised molecular classification, which means that we are going out to check for hundreds of genes, and it's like a fingerprint of the tumor. And basically, we have the luminal groups, which are the groups that have estrogen receptor expression, but also subsequent multiple genes that are expressed after the estrogen is bound to the estrogen receptor. And we have the ER negative, which are divided into the HER2-enriched and also the basal-like, which do not express the HER2, the ER, or the PR. And then there is a small group of normal breast-like. And what we have learned from two different groups, one is in Norway and Stanford, and the other one is Netherlands, is that the luminal A, the most common breast type, has a better prognosis as compared with all the other tumor types. But on the day-to-day practice, we don't use this unsupervised extensive analysis. So we use pathology subtyping, and we usually call luminal A for tumors that are ER and PR expressed, HER2 negative and low Ki67, and the luminal B may either not express the progesterone receptor or have high Ki67 or also express the HER2. And then our clinical focus is to see if we can precisely identify those patients who may benefit from both chemotherapy and endocrine therapy. And the multi-gene commercial assays are divided into two. One group is supervised analysis, which means that once they did the analysis, they already knew if the patient had a certain endpoint, like cancer coming back, yes or no. And once you have supervised analysis, sometimes you have to change your endpoint or your data may change a little bit. And we'll see that in the rest of the lecture. And the Oncotype DX belong to this analysis as well as the MammaPrint and the EndoPredict. The unsupervised is more looking at the extrinsic, but try to use lower amount of gene instead of the 100 genes, couple 10 of genes. So Prosigna uses 46 genes. So I'm going to focus now on the three tests that we use in Israel most commonly, which are either the Oncotype, the 21 gene assays, the MammaPrint with 70 gene assays, or the Prosigna PAM50 with 46 genes. So the Oncotype actually use equation that give you a number called recurrence score. And the recurrence score number is between 0 and 100. And there are several groups of genes that you can see here. And they're all multiplied by a certain number, and which give you the number. So this is the recurrence score, and we see it's a continuous predictor of recurrence. And these data are from the NSABP B14, which either gave the patient tamoxifen along. And here we see the 10-year distant metastasis for patients that use 5 years of tamoxifen. And you can see the low risk, the intermediate risk, and the high risk. And you can also question if a patient had a score of 30, what's the chance of cancer coming back distantly in the next 10 years? And what we have learned from NSABP B20, which either gave the patient tamoxifen or tamoxifen with chemotherapy based on CMF, we saw that when the recurrence score number was 0 to 25, the patient didn't seem to benefit from chemotherapy. But when it was from 26 to 100, there was a substantial benefit of giving those patients chemotherapy. So in the node-negative patient, the numbers seem to be both prognostic and predictive for chemotherapy benefit. And this is the TAILOR-X study, which recruit about 10,000 patients. And the patients with a very low recurrence score of 0 to 10 received only endocrine therapy. Those with a high recurrence score received chemotherapy and endocrine. And then patients with recurrence score 11 to 25 received either endocrine therapy or chemotherapy followed by endocrine therapy. And the primary endpoint was invasive disease-free survival. And they published those results showing that the patient that either received only endocrine therapy or chemoendocrine therapy had the same results. And these are the secondary endpoint of distant metastasis-free survival and also overall survival. And again, they didn't find any benefit of chemotherapy in addition to endocrine therapy in those women. So then they did exploratory analysis looking at the patient age. And what they found out is that the patients that were younger than age 50 and still menopausal, they did seem to benefit from chemotherapy. And then they tried to look at the benefit related to the recurrence score and what they called clinical risk, which look at the tumor size and the grade. And they saw that the most of the patients with recurrence score 16 to 20, the benefit was only 1.6%, but when the recurrence score was 21 to 25%, the benefit seemed to be 6.5%. And here is a summary from the large studies looking at node-negative patients. And what they showed here is for 80% of the patients that are taking the Oncotype test, they will not need chemotherapy, and only about 15 to 20% will benefit from chemotherapy based on the study results. And so the next question was, what's going on if the patient had 1 to 3 involved nodes? Are they the same? Is this the same biology? And it's exactly the same like the node-negative patients. And the RxPonder trial tried to answer these questions. So they recruited adult patients with HER2-negative, ER-positive tumor with 1 to 3 lymph node, including patient with micrometastasis. And if the recurrence score was over 25, they received chemotherapy. And then if it was between 0 and 25, one arm received chemotherapy followed by endocrine therapy, and the other received endocrine therapy alone. And they recruited 5,000 patients to this study. And they hypothesized that the higher the recurrence score, the patient will show more benefit with chemotherapy. And they had the third analysis just prior to the recent San Antonio meeting. And this is the patient population. As you can see here, about 2/3 were postmenopausal and 1/3 were premenopausal. And then the majority of patients, about 92%, had 1 to 2 involved nodes. Only 9% had 3 involved nodes. And they didn't show that chemotherapy and recurrence score interact, which means that they couldn't prove that the higher recurrence score, the more benefit you see from chemotherapy. And so they looked at the specific factors and they saw that the chemotherapy matter and that the recurrence score matter. And then they wanted to see if the chemotherapy affects differently women that are premenopausal and postmenopausal. And this is the invasive disease-free survival in the postmenopausal patient. And here they didn't find any benefit of adding chemotherapy. But in the premenopausal patient, there was a significant benefit of adding chemotherapy with the absolute 5-year invasive disease-free survival difference of 5.2%. And here you can see for the postmenopausal patient, the number of distant metastases look very similar, but for the premenopausal patient, it almost doubled without chemotherapy. And then they wanted to see if the number matters. So they looked at the recurrence score 0 to 13 or 14 to 25. And in the postmenopausal patient, it still didn't matter. And then in the premenopausal patient, all patients benefited from chemotherapy. And the overall survival benefit was already shown in the premenopausal patient by this follow-up. And so it's interesting, I told you before, when you have supervised analysis, sometimes the results change when they change your population. So you can use the recurrence score result of 0 to 25 in the postmenopausal node-negative patient and also 1 to 3 involved node to judge whether they can receive the endocrine therapy long. And then in the node-negative but younger patients or the premenopausal node-positive patients, there are recurrence score number that identify patients who may benefit from chemotherapy in addition to endocrine therapy. And now we'll move to a different test, the MammaPrint test, the 70-gene assay. And this is the MINDAX study, and it's enrolled 6,600 patients. And here we'll focus on the group that was clinically high but genomically low of 1,550 patients. And they wanted to see if they benefit from chemotherapy. And the primary endpoint of this study was focusing on this group and looking if the distant metastasis-free survival over 5 years is over 92%. And this is the group without chemotherapy. So you see it's more than 92%. It's 94.7%. And here you see that there is no benefit of chemotherapy in this specific group of clinically high but genomically low group. And here they analyze it by 0 lymph node or 1 to 3 involved node. And again, the study, the genomic study, gave us very good, precise population who does not benefit from the addition of chemotherapy to endocrine therapy. And they updated the analysis in ASCO 2020, and now they have 8.7 years of median follow-up. And what they still see, again, the number is still at 5-year, 95.1%, but when they follow those patients to 8 years, they do see the curves coming down. So the patient without chemotherapy do less favorable than the patient that received chemotherapy. But here they divided the patients into two groups. Those that are younger than age 50, they seem to have a substantial benefit from chemotherapy, and the distant metastasis-free survival benefit at 8 years was 5%. And then in the patients that were older than 50, they didn't seem to have any substantial benefit. So the two studies again show you the importance of the patient age and likely menopausal status. And what they mention here is that the majority of patients that receive endocrine therapy and were younger received tamoxifen alone, and only 16% of them received ovarian suppression. And they think that the benefit of chemotherapy may be related to the fact that it does suppress the ovarian function. But this is a hypothesis. And here they try to compare the two studies. So they show that in the Taylor X population, most of the patients were in favorable group, and only 26% belonged to clinically high risk, where in the MINDAX study, all the patients were clinically high risk. But other than that, we cannot compare the studies. And I will briefly go on the Prosigna Essay. So the Prosigna Essay try to look at the intrinsic subtype originally developed in the 2000 with 100 of genes, and then try to use a lower amount of gene ended with 46 genes. And those genes are expressed, and they give you the intrinsic subtype, but they also develop something like recurrence score, and they call it ROR, risk of recurrence, and they considered both the genes and the tumor size and the nodal status. And here they show some combined analysis where the ROR can differentiate between patients with low, intermediate, and high risk, and they show that, again, the majority of the patients with node negative, about 70%, will not benefit from chemotherapy. And on the right side, they show the node positive patient, and here about 40% will not need chemotherapy according to their test. And here they show that the intrinsic subtype give additional value in addition to the ROR. And the Prosigna do not have large prospective studies like we have with the other two tests, but just recently we heard some very interesting data actually from patients with metastatic disease from the Mona Lisa phase 3 studies. And those studies recruited patients with luminal tumors with metastatic disease and gave them endocrine therapy with or without ribociclib, which is a CDK4/6 inhibitor. And so here, if you look across the studies, you can see that about of those patients divided as luminal per pathology, 47% have luminal A tumor by the test. About 24 have luminal B tumor. And then you see about 13% that their tumor behave like HER2-enriched tumor. And you see also several percent, 3 to 5%, that the tumor by intrinsic subtype are basal-like. So they're not luminal at all. And if you look at the response rate, you see the benefit from adding CDK4/6 inhibitor to endocrine therapy in the luminal A and the B, and also the HER2 enriched by this study, which express estrogen receptor by pathology, but you don't see any benefit in patients with identified as basal-like. And these are the progression-free survival analyses which match the response rate. So it does give you the flavor that the intrinsic subtype give you additional information, and we gather this information now more in the metastatic disease. We're waiting for the early tumor studies. So if I summarize this lecture, the current recommendation for a patient with node negative, to use either the 21 gene assay with the oncotype, which is prognostic and predictive in this group, but you can also use the mama print. And then for the postmenopausal patient, there is level 1 evidence for the recurrence score, and also the 70 gene assay, either node negative and node positive from the MINDAX studies. If you take the proper population of clinically high, genomically low, you have level 1 evidence that you can spare chemotherapy. So if we summarize what we have learned, we know that the term breast cancer refers to several tumor subtypes, which can be defined by pathology and also by multi-gene assays. We have to learn how we learned from the multi-gene assay studies, what questions they had, and also if it was supervised or non-supervised analysis, because if it was supervised, then sometimes we get different results from different group of patients, like node negative and node positive, pre- and postmenopausal. And stage, especially nodal status, age, and menopause are still very important, as well as the patient preference. Thank you for your participation.